Welcome to PCR webinar. First stent in left main PCI, simple but not too simple. It's a continuation of bifurcation continuum. We are back live in Paris. My name is Goran Stankovic, and I have with me in studio Francesco Burzotta from Rome and Jacek Legutko from Krakow. So we have exciting session today, and the goal of this session is to discuss step-by-step approach to implantation and optimization of the first stent in left main PCI. Of course, discuss pertaining evidence base, discuss the use of imaging and physiology to guide the procedure, and learn the most important pitfalls of implanting the first stent in left main PCI. Discuss prevention and measures for each of the pitfalls. Please use the chat box. We will be happy to answer any question or concern you may have. And to start, we will present the case. Francesco, let's start with your case to introduce the topic.
Okay, so the case I want to share with you is this one. Is a male, 50 years, so young, classic risk factors, in particular familial history. And he had, as a cardiovascular history, an history of chest pain that was atypical, but he underwent cardiological examination showing a normal echo and a positive exercise test. So he underwent a CT scan that showed diffuse atherosclerosis in the distal left main LAD and a tight ostial lesion of the circumflex artery. This is the coronary angiography. The right was, unremarkable. Here you see the two views for the left system showing diffuse disease into the mid-LAD, but without clear stenosis. There is tight ostial lesion on the circumflex, and there is also some irregularity into the distal left main. So if we are looking to treat this kind of lesion, I think that is very important to know very well the anatomy, and in doing this we have different opportunities. Intravascular imaging by IVUS or OCT are the main one. I decided to go with the OCT. This is the pullback into the LAD that allowed to rule out the fact that there was stenosis into the mid-LAD, and also at the level of LAD ostium, there is no significant disease and wide lumen. On the opposite, there is some plaque into the distal left main. You may see it here. And in the other pullback that was over the circumflex, we really confirmed this tight lesion into the distal, into the ostium of the circumflex, and also the irregularity in the lumen induced in the left main by the plaque. So this is.
I think, Francesco, you can show us on this smart board what was the plaque distribution and what was the decision making how to treat.
So I think that only after imaging you might be 100% sure about the distribution of the plaque in your distal left main. And here we confirmed what was obvious, that there was here the plaque into the ostium that was inducing tight stenosis. However, it was also evident that here the LAD had no significant disease to be treated, and on the opposite, there was some plaque into the distality of the left main, confirming the fact that there was, especially in the cranial view, some irregularity. So overall, what I think is that the coupling between this acute angle and this plaque distribution really call for the use of provisional here, not trying to fix the ostial lesion with the stent just put down, and to use this as the main operative vessel, since plaque is more distributed in this axis as compared to the other one.
Yeah, excellent. So with that single stent, idea is to compress this plaque at the ostium of the circ, cover completely disease in the left main, and then optimize the result. Can you lead us through the steps and explain how actually was the procedure performed.
So,
If we can have slides
back, please.
Back.
Okay. So the PCI was performed, so as we discussed, according to the concept of inverted A or inverted provisional. According to this, we have been able, due to the fact that we knew the sides of the circumflex, we pre-dilated it with 3.5 by 15 non-compliant balloon. Repeatedly, this was the angiographic result after that, and then we implanted a stent from the ostium of the left main to the circumflex, so to perfectly fit with the ostium, we went into the cranial view. The stent was delivered here at nominal pressure, and this is the angiography showing that if you respect really the distal main vessel size with your stent, even in acute angles like that, you may have preserved flow inside the LAD. Then we did the next step, which was the POT with a 4.5 by 12 semi-compliant balloon. And after that, we move forward to perform a rewiring of the LAD. You see here that there is a good technique that allows you to have higher chance to go close to the carina with your wire, that is pullback rewiring. And you may see here that the radiopack marker of the wire, the tip, allows you to really see that it is very close to carina. When you see this, the next step are the possibility to open up with the sequential kissing. We like very much the idea to do it kissing sequentially and with non-compliant short balloon. So we performed high pressure dilation with on the circumflex, then dilation to check expansion with the balloon inside the LAD, and then the kissing balloon at nominal.
Can I interrupt you for a second?
Sure.
We received several very nice comments and greetings from Dhaka, Bangladesh, Pakistan, Uzbekistan. Thank you for all these questions. We start with Harrison Go, who says plug distribution seems to support provisional to LCX with keep it open on LAD. This is not exactly keep it open. You did kissing, so what is the reason to do kissing instead of just pot? So, I mean, we know that kissing is not associated with a clear long-term advantage in terms of clinical measured adverse events. However, I think that if you have a young guy, like it was this, with a long measure LAD, with some plaque inside, it really makes sense to at least open the door for, in the case of future disease progression and this stuff. Perfectly agree with you. Just to summarize for our colleagues, long-term follow-up data of kissing versus no kissing do not show difference in clinical outcome, no difference in mortality, but those overlapping survival curves can be interpreted also in the way there is no penalty if you perform kissing. And I agree with you, Francesco, that young, very long disease already present in LAD, really we may expect some disease progression. So doing kissing is beneficial, at least in my view.
Yes, just a small comment. Since we know that kissing is not associated with long-term outcome benefit, I think that we should really pay attention if we decide doing it properly. Because we know that kissing effect on the stent is strongly dependent on the site of wiring. This is why I showed this rewiring phase.
Can you show us the final results? And then we have questions from Dr. Huma.
So after that, we performed the re-POT in order to be sure that there was the possibility to have some oval deformation that is fixed. And this is the final result into the cranial view. You now see that the left main is bigger, and you see here, I think, a fantastic result into the ostium of the circumflex. This is magnification. However, anytime we open up the device for imaging, it makes sense to check the final result
throughout the procedure.
And so we checked what is regular, no dissection at the edge, very nice opening of the stent at the ostium. And here, very important, removal of all stent struts at the carina level, and also absence of dissection into the ostium of the LED that is apparent over there. And finally,
so no need for stenting LED, that's the
exactly,
message.
Exactly. And finally, a huge left main that reached more than 17 millimeters square. So all of this is associated usually with good outcome, but we have now also the possibility to see the outcome of the patient, no significant cardiac enzyme, discharged the day after, return to normal life, CT scan performed to check how is going the things. 14 months showed the patent left main. And also, you see that I decided to cover up to the ostium. So you see that there is some floating struts. We will see during this afternoon together the impact of that. And there is also the possibility to check that the stent was fenestrated with a good opening toward the LED. And at 30 months, actually, the patient is asymptomatic, normal life, and exercise that is HG negative.
We have several questions. We should try to be very focused and answer. Dr. Huma is asking, what would be the recommendation of the panel if there is significant disparity of diameter between left main and the circ, and you have again isolated ostial circ? What would you do?
I think that what is very important to recommend is to know very well, first of all, the sides. So this mismatch should be verified by intravascular imaging. And the other point is to select a platform that is able to accommodate these differences. So you should know very well the drug-eluting stent you have in your lab.
Excellent. Greetings, Dr. Bunas. Greetings from Greece. What about kissing using DEB in LAD?
What about? We need to have
data. We need data, but it's a very good suggestion. Do you, Alessandro Beneduce, do you always perform repot after kissing?
Most of the time, honestly. Anytime I have the possibility to do, I do.
Jacek, yourself? Kissing, pot, repot?
I always try to finish the procedure with POT.
Okay,
even after
so pot, kiss, pot for big bifurcations, for left main, agreement between all three of us.
May I give the true reason I do it?
Sure.
It is related with the fact that the first pot, most of the time done with the jailed wire, is not as aggressive and appropriate as the last pot, when you finish everything and you want, really to take care about the expansion and that position.
Dr. Yuri Melen, sorry. What about aggressive lesion preparation with cutting or scoring balloon? And if good result, DCB in the ostium of the circ?
Honestly, we need data. We are focusing now.
Thank you for your suggestion. Excellent idea. We need to investigate in the trial. Dr. Sarkisian, is it repot necessary for this specific case? Yes, it's part of your strategy.
I think that I mentioned why. I would like at the end to finalize with very good apposition of the stent.
Yeah. Francesco, while we are waiting for the questions, please share with us evidence-based that we have. You nicely explained pot, kissing, the role of optimization, but do we have the evidence for that?
So honestly, I think that during the last 2 years, there were accumulating data regarding the safety of provisional inside the flow of left main bifurcation intervention. This is probably one of the most important study published in European Heart Journal. That was the EBC-MAIN, in which patients really, with nasty lesions through bifurcation, most of them Medina 1-1 lesion, have been randomized to systematic dual stenting of stepwise provisional. And I want to highlight how was conducted the provisional approach that was, first of all, POT mandated, kissing balloon mandated, and side branch stenting was allowed according to T-tap or culotte. So provisional was not just one stent. And the results were, let's say neutral, but you see the bar, there were comparable clinical results at 1 year. The other important study I would like to mention is the Rolex Registry, mainly organized by Giuseppe Tarantini. It was conducted in Italy and Portugal, and it was performed with the Onyx stent that was also the same for EBC-MAIN. And it was focused on 450 patients with similar inclusion criteria of the Excel trial. And the procedures were, as expected, reflecting the real world of our life, a lot of transradial approach, 45% of the cases guided on imaging, and there was also 80% of single stent procedures at the end, and the target lesion failure was as low as 5%. So very remarkable results. And what was interesting was that when we split the data according to angio guidance or the use of imaging, either IVUS or OCT in the trial, it was really apparent to see that the IVUS was associated with very promising data, I think.
I think that's phenomenal and goes very nicely with question of Dr. Akhmedov. What about IVUS and doing the last pot? I think use of imaging clearly demonstrated in the Rolex that if you use imaging, you are really assessing exactly amount of plaque, plaque distribution, landing zones, vessel size. So you can really plan your strategy. And to come back to first question, you can really select the platform, even larger one, deploy at a lower pressure, and then optimally deploy inside the left main. So I believe that imaging, especially for the left main, and I'm sure that both of you agree, is really something that we should strongly recommend, if not even mandatory. Jacek, I know for you 90% of procedures are IVUS guided.
Within the left main, that's true in our center, 90% of IVUS use. I believe that it was beautiful demonstration, not with IVUS, with OCT, but we are talking about intravascular imaging. That it allows us to perform appropriate planning, and many times we switch from angio planned to stent strategy into just provisional stenting strategy, which is, I believe, very good for patients.
Yeah, very good question also from Dr. Ngo Harris. Could this subset of patients be suitable for jailed balloon technique in the LAD? Francesco, would you consider, you were one of the first promoters.
So I think that jailed balloon technique should be reserved on the opposite when you have really a lot of plaque inside the side branch. However, the beauty of jailed balloon technique was the fact that we discovered the fact that we may use it on bailout in the case we have not anticipated really the risk, or we did some mistake during our procedure. So it is also important.
Thanks. I think we stop here with beauty, and now we go to ugly. So we go to pitfalls. And with courtesy of my very good colleague and friend, Dr. Thierry Lefebvre, we got this case. So it's left main 101. You see calcified, diffuse disease, most of the plaque at the ostium of the circ, although there is significant disease in distal left main, ostium of the LAD, unstable angina. So the plan was to use prophylactic balloon pump and then direct stenting from ostium of the left main into the circ. 3.5 by 24, of course, 2 wires, extra backup catheter. And after that, wire exchange. And after exchanging wires, kissing balloon was done and no pot. What happened after that is this final result, which I think both of my colleagues agree, angiographically looks perfect. But then they did IVUS pullback from the circ. And please look on the left side, you have angio. On the right, it's IVUS pullback. So far, we see within the stent good expansion, symmetrical, circular lumen. Okay, now you see the arrow, and I will go to the smart board. I think it's much easier to understand what happened and why we had this compression of the stent inside the left main. So they didn't do pot. And after deploying stent from the left main into the circumflex, they simply pull back the wire that was inside the stent and then went with that wire in the LAD, pull back the wire from the LAD that was jailed, and reinserted in the circ. Reinsertion of the LAD wire was actually, according to this IVUS imaging, abluminal, outside of the underexpanded stent inside the left main. If you see this cross section, this is a wire that goes into the circ abluminal, and this is the wire that goes through the stent into the LAD. So when you do kissing balloon inflation with this position of two balloons, you actually compress the stent. And by compressing the stent, you actually create a good angiographic image that is not easy to understand the problem that is mechanistic inside, and you have potential nidus for stent thrombosis. So we focused the last 16th consensus document of the European Bifurcation Club specifically on these aspects, pitfalls, and we tried to understand how to troubleshoot and prevent these complications. So this is the case that illustrates abluminal left main stent rewiring from the aorta, you see in red. So after couple of struts abluminally, wire re-entered inside, and we have a solution how to troubleshoot in this case. You use dual lumen catheter on the abluminal wire, and you use over the wire lumen to position precisely wire inside the stent. On the lower left side, you see confirmation by OCT that the wire was actually abluminal, and after that we have confirmation again by OCT that with image guidance we are able to reposition, and that's also confirmed by 3D reconstruction. This is very similar pitfall, just wire does not go throughout the length of the left main abluminal. It goes couple of struts outside of the stent and then re-enters the stent through the stent and then enters the circumflex. So if you need to go with additional balloon to boss dilate, to do kissing or to do imaging, you have resistance and catheter stops in the aorta at the proximal edge of the stent. What we recommend to do in this case is to use again on the wire which is inside the stent, again dual lumen catheter, and then using the same maneuver, position through the dual lumen catheter wire inside the circ, and then repeat pot in order to correct this under deployment. And we frequently recommend to do pot throughout the proximal length of the stent in the main vessel, in this case of the left main. So if we just do pot distally at the carina and we don't expand the full length of the proximal stent, we will have gap as presented by this arrow. So our wire will go abluminal, then inside the stent and inside the circumflex. And if we go with balloon on that wire, by inflating kissing balloon, we will actually create even larger gap. If we perform pot at this stage, we compress that wire and we actually jail wire between the stent and the vessel wall. So if we need device like another balloon or imaging catheter, that device will again stop inside the stent, and this is mechanistic explanation what actually went wrong. So what is the solution? Again, we can still have the wire inside the stent, use again similar technique with the dual lumen catheter, and then use the lumen to rewire centrally through the stent into the circumflex, and then mandatory pot at the proximal edge to fully deploy. So if we don't have a dual lumen catheter, Francesco, there must be other solution. What would you do in your practice?
So honestly, the first message for me that I learned from all this stuff is the fact that we should never push without against resistance.
Exactly.
This is important to take in mind. Regarding the possible solution after having recognized that there is this problem, you may also try to, with another wire, with a long band, trying to have it crossing the stent, be in the center due to the loop. So this is what I try to do. And also, I mean, what you mentioned, it makes sense. But take-home message should be that in the absence of anticipated resistance, if there is resistance, do not push and try to understand what's going on. And imaging helps you.
Yeah. Jacek, additional tips and tricks?
I changed my practice in the last years because I do most of the procedure, as I said, with intravascular ultrasound guidance. So my approach to rewiring is nowadays quite simple. So it means that I use third wire for rewiring to the circuit. This is first. Second, I use IVUS probe to check if I am going with the wire through the lumen of the stent and not, like you said, between the stent and the vessel wall. And that time I can also check the quality of the first pot, because sometimes if I see that stent is severely underexpanded, I decided to stop rewiring, first optimize pot, and then go with the wire to the side branch. These are my tips and tricks for this.
Yeah, just to summarize for our colleagues. So when we have deployment of stent, especially in the left main, there is a huge discrepancy in diameter between the left main and two daughter vessels, LAD and the circumflex. So this discrepancy in diameter is corrected by adequate proximal optimization. If we don't deploy a larger balloon to fully expand the stent, what can happen? Option number one, and I will take a different color maybe to enhance understanding. Option number one is that your wire from the guiding catheter goes completely abluminal and then inside the stent. And then you have one wire through the stent in the main vessel, one wire abluminal, and when you do kissing balloon inflation, with kissing you actually compress the stent. And this is not easy to understand from angiography. Option number two is that your wire does not necessarily go throughout the length abluminal. Just after a couple of struts, especially if you have this kind of position of the guiding catheter, can go couple of struts outside and then inside the stents. So two pitfalls that I try to illustrate using figures from our consensus will help you understand that if you have device that stucks, gets blocked in the proximal edge of the stent at the ostium of the left main, could be one of possible explanations that you don't have full expansion and deployment at the ostium. So do pot, then do imaging if you want to confirm, and then continue with the procedure. Only adequate stent expansion, so this is bad, it's not good. Adequate stent expansion with pot may allow certainly easier flow of the procedure. So this is first part of the pitfalls that I wanted to share. And second one, again, very frequent. I'll show again two cases that it's not really a case, it's just illustration. This is the angio at the end of provisional two-stent strategy for left main. Again, angiographically, I think looks very nice. And this is CT after 6 months. Look, clear deformation that was induced by the guiding catheter during the procedure. This longitudinal deformation at the proximal edge was not clear. If you see the final result was really optimal, you don't see it by angio, but you need to keep in mind that contact between tip of the guiding catheter and the stent can create deformation. And we learned from the Excel IVUS sub-study that this is not rare. Longitudinal deformation was present in 6.7% of left main stents in the Excel and correlated with adverse outcome, even with mortality. So we need to be careful. And how it occurs, this is case B, the second case. So diffuse proximal LAD tortuous disease, and direct stenting with the long drug-eluting stent, 38 3.5. And then what happens is that I can illustrate again on the screen. What happens is that during the deflation, operator did not wait until balloon was fully deflated. And having a wire which is jailed without fully deflated stent, when you pull back your device outside, your catheter gets sucked inside. And you actually damage the proximal edge by the guiding catheter that unintentionally enters inside the left main. As a result, there is image that you see that now you have stent deformation, so stent is not present anymore at the ostium, plus with the guiding catheter contact, you actually create damage and deformation of the stent. So what should we do in this case? In this case, what we need, can we go back to the slides? So this is non-covered part of the left main, and what you need to do is to correct this deformation created by the contact with the guiding catheter, performing adequate POT. After POT, finish procedure with kissing balloon inflation, and then add second stent to fully cover the ostial part of the left main. Any comments or suggestions on this?
I believe that we should stress what was mentioned by Francesco, that first POT, usually we don't use very high pressures, especially in patients with calcified left main, because this increases the risk that during the wire removal from the out of the stent, you can create this movement of the catheter towards the stent and create stent distortion. So this is why the second POT is afterwards very important to optimize the result using high pressure.
Yeah. One small comment. I think that it is also very important to keep attention at this phenomenon. So while you are pulling back your devices, or you are concentrated in other things, it is important that you always take attention at the tip of your guiding catheter. And honestly, I also try to do like that if there is no very complex lesions needing high backup from the guiding catheter. I try to use a little bit undersized guiding catheter to treat left main in order to have this phenomenon less apparent.
Yeah, there is good question which goes again well with your comment. Dr. Pavlos Bunas is asking if the proximal left main is free from disease according to intravascular imaging, do you suggest stenting up to the ostium or not, especially if the left main is long? I think it's...
Yes.
Please.
No,
yeah, go ahead.
I think that it is not, it is not mandatory, especially if you are 100% sure by intravascular imaging you are, that is undiseased. However, in my experience, the vast majority of the left main, when you go to assess them by imaging, have some disease.
Yeah, Jacek, you have huge experience in image-guided left mains. What are your criteria to decide on the proximal landing zone? This is actually the question coming from our colleagues.
With pre-interventional IVUS, I will usually check for the plaque burden, which is in the ostium of the left main. If it is more than 50%, I always cover the ostium. If it is less, and especially with big lumen in tapered left main, I do not necessarily cover the ostium, and it makes the procedure much more easy, because positioning of the stent just in the ostium of the left main is sometimes tricky.
And also when we speak about reduction in contrast use, I believe that your experience with IVUS really, in addition to providing important information for planning the procedure, reduce the total amount of contrast that you use and therefore reduce the risk of contrast-induced nephropathy.
Of course, you don't need to make multiple projections to see what happens, to measure the sizes and to orientate on the plaque distribution, so it definitely lowers the contrast volume.
Yeah, so if we go back to the slides, just to summarize the mechanism of longitudinal stent deformation. So be aware of the damage that you can make by having contact with the guiding catheter and the proximal edge of the stent. Of course, in case that you stent from the ostium of the left main. Be aware that whenever you do pullback of balloon or IVUS, especially while having jailed wire on site, you have higher risk that guiding catheter will jump in and deform the proximal edge and create stent deformation. Also, if you pull back a jailed wire from the side branch, be aware that what we routinely recommend is to completely disengage the guiding catheter, left arm control of the guiding, guiding catheter outside from the ostium, and then slow pullback of the jailed wire, carefully observing the position of the guiding catheter, but also the movements of the jailed wire. Don't pull, be very gentle, pull it very slowly, and with new generation of guide wires, you will not have problem to disengage majority of wires. So this is one part of the reasons for having longitudinal deformation. Second part relates to side branch salvage strategies. And if you use jailed wire in case of compromise of the flow in the circ, we advise to use jailed wire underneath the stent, small balloon on the jailed wire to create space and to provide visualization of the circumflex in order to reopen the vessel. Of course, during these maneuvers, especially while pulling back the small balloon from the circ, we can again have deep engagement of the guiding catheter and severe deformation. In general, whenever you face difficulty and you are not sure what happens exactly inside the substrate, inside the stent, please stop, use imaging, whatever you are most familiar with, evaluate the reasons for mechanistic complication, try to understand, and then base strategy on clear information what was the cause of complication. With two expert images, if you want to add something.
No, I think that you really summarized very, very clearly all the stuff. The truth is the fact that this mismatch between the distal main vessel or the side branch and left main is something that should be recognized during our intervention, and it is we should take care about this more and more in our procedures if we want to have smooth procedures.
Yeah, Francesco, question from you from Yuri Melen. If we have wide angle more than 70 degrees between LAD and the circ, is provisional strategy which you demonstrated, left main circumflex crossover, still suitable?
I think that it is suitable because it is even if you have a 90 degrees angulation, even in the case you need to implant the stent inside the LAD, you will do it more easily after having implanted the first stent inside the axis of left main to L circumflex. So this is what we say also the inverted provisional as a strategy to implant two stents. So it makes sense, I think.
Question from Vivek Chaudhary. Does dual lumen catheter damage the stent or vessel? If you are coaxial and with careful manipulation, and if POT especially is performed, the risk is very low. So the benefit from using dual lumen catheter to wire throughout the stent, I think, enhances the risk of damaging the stent. You agree with that?
Absolutely.
Dr. Islam, please share your tips and tricks on abluminal wire to understand for us who don't have abluminal dual lumen catheter, I guess. We already discussed one strategy is to make a larger curve, try with a loop to enter from the guiding catheter into the stent, position that wire throughout the length of the stent towards the LAD, and then while pulling back, try to engage the ostium of the circ. less reliable. Stent enhancement software may help you understand the position of the wire in case that you don't have imaging. But I think one that is for me really superb is to guide procedure with imaging. So I think imaging is extremely important. We cannot stress enough the value that we get. But let's go to the last part of our pitfalls. So I showed cases of stent deformation with the compression, but sometimes we realize, sometimes even at follow-up, that we can have stent elongation and protrusion. So Jacek, please share your case with us.
Yes, the number of left main PCI procedure is going up, so I believe that we will have more and more such cases that I would love to present at the end of this webinar. And this is the gentleman who came back to our CAD lab with non-ST elevation myocardial infarction after previous left main PCI with 2 stent strategy. The patient is with also aortic stenosis, maybe future candidate for TAVI procedure. Due to STEMI, we of course performed control angiography. And as you can see and appreciate, the right coronary artery is quite normal. And then operator started to inject contrast into the left coronary system. He tried to engage the catheter deeply to the left main. It was not possible. However, the opacification of contrast in the left coronary system is quite okay. He did multiple projections, was not really sure what happens in these patients with STEMI. There was a suspicion of the disease in the ostium of the left main, which is maybe the best visible in this epicranial projection. However, what was not recognized since the beginning, and it was not described in case history, became clear after fluoro was enhanced from low to high fluoro. Now it becomes clear that the problem with guide insertion into the left main is because this stent is protruding into the aorta, but not 1 or 2 millimeters like we usually do during our procedures, but more than 5 millimeters into the aorta, which makes, of course, this procedure much more difficult. This is also well visible and better visible when you use cine images, moving pictures, not just the steel frame. And the question is how to facilitate this engagement. If you manipulate with the catheter, trying to do without control, of course, you will also increase the risk, what was said before, of stent distortion. Even at follow-up, it is possible to damage the stent. So how to proceed with this? And of course, I believe that the dual double wire technique is more and more commonly used.
Yeah, you can show us on this smart board how...
Yeah, the problem is that, of course, if you have such strongly protruded stent into the aorta, your guide catheter usually tends to go just below the stent, under the stent, but not necessarily in the ostium of the stent. So this causes the problem that the first wire usually goes to the artery, to the left main and LAD through the stent struts. And of course, you can try few times to find the appropriate way, but the better way to go is just to push this wire distally, non-hydrophilic. Usually, for this purpose, you use just BMW wire. And then when you push this wire, your guiding catheter will go back.
Disengage.
Yes, disengage. And with, of course, this maneuver, we would love to go to the situation where the wire goes that way, and your catheter now would be just in front of the stent, which is not always easy. And so this is the first trick, to use the first wire to maneuver, to facilitate the engagement of the guiding. But the second is to use another wire, trying to engage this wire, but I always check with intravascular ultrasound if I am going through the lumen of the stent or just through the stent struts.
If I can summarize while you are starting your slides, attempt is to push this wire, which is soft but not hydrophilic, to disengage the catheter and have more favorable position of the catheter, which will allow you to somehow do fishing and to try with the second wire to get the through lumen. which needs to be confirmed by imaging.
Of course.
I saw already your nice images. Please share with us.
And
Excellent.
This is what I tried to do in this particular case, and to be honest, it was not very easy. It took me more than 45 minutes, and I used 3 different guides. However, all the time I tried the same strategy, using this first wire to stabilize the guiding and try to position the guiding opposite to the ostium of the stent. And this is the picture that on angiography it looks like the probe is going inside appropriately. However, there is a resistance, and what we see on IVUS, we clearly see that the second wire is also going through the stent struts. You see that the stent is lateral to the probe, so it means that this is not appropriate. Of course, if you do not recognize this, if you are too aggressive, you can damage the stent. This is another way to create longitudinal stent distortion. So of course I changed the guiding and even use less aggressive 3.5 Judkins. As I said, you have to be very gentle with all these manipulations, not to damage the stent which is protruding into the aorta. And sometimes it takes a lot of time to appropriately find the way to the stent. I was not really sure if it is appropriate again. So again, I used 2 wires. And on the second wire, there was a probe, and finally, this probe entered the lumen of the left main. We will see if it went through the stent struts or
see the IVUS catheter inside.
The IVUS catheter is inside the left main, and I very gently pull it back. So this is very important, not to be too fast. And now you see what happened in this patient. You see some maybe neointimal proliferation. On top of that, for sure, some thrombosis. Maybe there is stent rupture. It is not clear from this picture. However, there is a stenosis in the ostium, and this stenosis caused the event. However, with this IVUS pullback, I also proven that now my wire is going through the lumen of the stent and not through the stent strut. So if you are in this situation, the rest of the procedure is quite simple. I decided to use another Resolute Onyx stent, and I did it just the direct stenting, short stent, post-dilated with appropriately sized balloon, which was, of course, sized according to IVUS diameters. And this is the final pullback. Now you can see we are again in the left main, and I try to pull back gently, because again, if I am too aggressive, I can damage the stent. And you can see 2 layers of the stent very well opened. And of course, the stent is still protruding to the aorta. However, now you see that the probe leaves the stent just through the ostium of the stent and not through the stent struts. This is the strategy which I believe would be necessary in more and more of the cases, because we do more and more left main PCI procedures.
Excellent, bravo. Really, congratulations on fantastic. This is a super skilled operator. I really admire this very thorough explanation of your success. Question for you from Dr. Jan. How much length of the stent is acceptable to protrude in the aorta?
We should just cover the ostium. So usually we protrude by 1 millimeter. It depends on the angulation of the ostium of the left main. But this usually happens not by intention. Operator didn't want to do that, but just during the stent implantation, probably stent jumped back to the aorta, or operator used not appropriate projections and angioprojections to position the ostium of the stent, because this usually happens if you position the stent in spider view or array view, which is absolutely not acceptable during left main PCI. We should always position the proximal edge of the stent in epicranial or laocranial projection.
To make sure. But sometimes he takes deep breath, and then position is very unstable. Dr. Erimescu, very good question. Did you use at any time balloon or stent to flare at the ostium of the left main when you pull back the balloon?
All the time. This is also regarding the second or final pod, that if I do this many times, I use compliant but semi-compliant balloon instead of non-compliant at high pressure, and this allows to flare the stent much more in the ostium. I didn't use the dedicated devices. There are such on the market, at least in the United States, but usually I use semi-compliant balloons.
Yeah, from Bogdan Janusz, you have super trick. Thanks for sharing. Many congratulations from Dr. Angulo, very nice trick. So this is really, I think, good in case that we face. I think this was a really clear way to go. But Francesco, question for you. I think this is something that you already done. Narayanan is asking, if we are still unsuccessful in getting into the ostium, can we crush the proximal protruding part of the left main stent?
So honestly,
maybe if you want, you can draw it on imaging. I think it's easier to understand if you draw.
So what we have is we are talking about a situation where our
just a little bit aside on one or the other, so they can see
yes, exactly.
Yeah.
So this is our situation in which our stent was really protruding a lot here from the ostium, and so it was impossible. Let's imagine that it was impossible, probably because you don't have the hands of as a Goran to get through here. So if really this is huge and you are unsuccessful in doing it, is sometimes, I mean, you may, as a bailout strategy, to try to enter here and to balloon here in order to create a new situation where your stent is used as the side, like in bifurcation, and the part of the stent is, I mean, left down and crushed down.
Mm-hmm.
All the time you do like that, it makes sense to be sure that you fix the ostium, because in doing this, it is possible that you do not cover part because you remove the stent. So you need really to add a final stent here to be sure that you cover. Honestly, the main concern is related not with the coronary artery, because this crushed stent probably is tolerable, but here, in most of the patients, we have the aortic valve. Let's say in all the patients, we have aortic valve. So the main concern is regarding the possible damage of the leaflets of the aortic valve with the crushed stent. So this is the, I mean, explanation why this is not the recommended technique all the time. You see this, but I mean, it should just be regarded as a bailout strategy.
Yeah, there is exactly the same comment from Federico Archiletti. He says, thanks for great talk. If we cross protruding in aorta stent abluminally and crush aortic struts with balloon and then cannulate left main, may this strategy create future problems? So this is exactly what you explained. There is potential risk for the cusp, but also you suggested to implant at the end stent to finalize procedure with the optimal result. Plug distribution seems to support provisional from, this is a later question related to your case. And Dr. Ahmedov is asking, do you use Szabo technique for ostial lesions, providing wire through the one or two proximal stent struts?
So Szabo technique is, I mean, a complex technique. Even it seems to simplify, because you have to decrimp a little bit the stent in order to get through the proximal strut a wire. I know the technique, and sometimes in my life I used in very, very, very selected conditions when it looks really something that may facilitate your life. Because even in bench test, the Szabo technique has been documented do not warrant 100% success in the precision. So this means, and it opens to the risk of having problems in retrieving the stents that you decrimped. So do it carefully.
Yeah, as far as I heard, Dr. Szabo is not doing Szabo technique anymore, so I guess this is along with your questions.
But many people still use floating wire in aortic root to better visualize the ostium of the left main, and also not to allow guiding to engage the left main during stent implantation. So this is probably more commonly used. However, what is, I believe, the best option is just to try to find the best projection, and maybe in the future and near future, when we will do more and more CT angiography before cath, it would be much more easy to find appropriate projection without, necessity of multiple contrast injections during the procedure. So I believe that the good projection for ostial positioning of the stent is the most critical issue.
I think this was perfect. Francesco, I'd like to use this couple of minutes to ask you to enhance message that you shared last week during the EBC meeting on visible heart lab and evaluation of the importance of sequence of stepwise provisional to achieve optimal result. Can you please just give us landmark conclusions?
So I should come to the, not the last, but the previous consensus on the EBC. We recognize the fact that most of the work in the past was focused in bifurcation regarding the stenting, where to place the stent, how to place the sequence for stent. But we now know that it is very, very important also the sequence of ballooning technique. And the ballooning technique like pot, kissing, and side branch dilation isolated have strong potential to induce distortion into the stent struts. This means that we should not only focus on the fact that we should apply POT properly sized, but also the timing for doing it. I mean, we mentioned during this webinar a lot of complications related with the fact that we are doing simple provisional.
Exactly.
So it is very important to recognize that we should fix, for example, malapposition in crossover stenting in the proximal main vessel as soon as possible. And especially if this malapposition is huge, like expected in large bifurcation like left main. So I think that this is an important take-home message for all participants.
Yeah. First of all, I would like to thank you both for a fantastic session. I'm so sorry that we have only 60 minutes. We answered, I think, all the questions that we received. If you have more questions, please send. We will try to offline respond. For us, sharing experience, practice, and technique is extremely important. During this webinar, we learned that provisional stenting has a sequence of optimization steps. Performing adequately and following the recommendation for pot, kiss, and then final pot ensures the risk of complication is minimal. Feel free to use routinely imaging for left main PCI. It will help you better understand plug distribution and composition, decide on the devices that you will use. You saw in the Rolex that if you use imaging, there is 50% higher chance to select a larger stent platform. A larger stent platform will allow you optimal expansion inside the left main. It's a huge vessel, and by having optimal expansion in the position, we decrease the rate of potential complications. I thank you both for excellent cases. We will have very soon the second webinar. We go step by step from provisional, but I would like to thank all our participants for fantastic and stimulating questions. I would like to thank Medtronic for organizing again this series of webinars. Bifurcation Continuum 2022 will have 4 sessions. This is just the beginning. Please write on PCR Online what else you would like to learn more, what are the difficulties that you face in everyday practice, and we will do our best to support you and share with you our knowledge and experience. Thank you very much, and looking forward to next webinar on bifurcation PCI. Have a good day.